we're ready.
All right. Welcome, everyone, to our 19th virtual shadowing session, Humanity and Medicine, with Dr. Raymond Fowler. If you have any questions regarding our program, please contact us on our Instagram at virtual shadowing or email us at virtualshadowing@gmail.com. If you miss out on the session or need to leave early, this recorded session will be posted on our YouTube channel, Pre-Health Virtual Shadowing. Next, Dr. Fowler. So our sessions coming up after this are especially spotlight in anesthesiology, especially spotlight in psychiatry, and a specialty spotlight in neurology and radiology. So don't miss out on those. Those will be on Zoom or YouTube Live at 7 p.m. Central Standard Time. Virtual shadowing is brought to you by the working group composed of Reagan, Cheyenne, Taylor, Elena, Rachel, myself, Ani Ruth, Miriam, Rohit, and our two wonderful providers, Dr. Fowler and Dr. Marchetti. Next slide, please. If you have any questions, please put them in the chat as we go along. Our wonderful working group will be collecting all these questions to be asked during the two designated Q&A sessions, one at the middle and one at the very end. If you have any questions regarding the assessment, please wait until the very end after the last Q&A, and we will show you how to access the assessment. As always, these sessions are about 1.5 hours to 2 hours. Next slide. So without further ado, we have Dr. Fowler joining us today. He is Professor of Emergency Medicine at the University of Texas Southwestern, James M. Atkins, MD, Distinguished Professor of Emergency Medical Services, Chief Division of Emergency Medical Services, attending emergency medicine faculty at Parkland Memorial Hospital. He has been an incredible mentor and provider, and without him, without his drive, his ambition, his gracious time, energy, and resources, virtual shadowing would not be here today. So please give a warm welcome to Dr. Ray Fowler.
Well, welcome everybody. It's so nice to have you all here from nearly all over the world. Today we hit, in terms of total people that clicked sign up on the website, Virtual Shadowing, we've hit 25,480 people. We call that list a bit when they're duplicates, representing over 740 universities worldwide. We had no idea what we were starting when we did this. We've had a lot of wonderful talks along the way, everything from physicians in business to Brandon's wonderful talk on SWOT medicine to Christo Phillips' marvelous talk last week about being a man of faith and being a physician. Tonight, we're going to talk about the humans behind the doctor, and I'm going to share some things that are my point of view, the way I think of them, because you asked me to speak. Next week, we'll have somebody else, and they'll talk about how they think of things. But I just want to share my thoughts with you and some of the things. I'm 67 years old. I've been practicing medicine 43 years. I've been around a long time. A couple of 100,000 patients now. I've made a lot of mistakes. I study all the time because that's what it takes to do this and do this safely. And so what I would like to do is I'm going to reach into your heart so you can look a little bit and find out who you are as someone who is seeking out an experience, a career, a lifetime in medicine. And I'm going to bring this from a lot of different angles. And what I would like you to do is sort through that. And what you're going to find along the way is you're going to find many brilliant people who give you ideas and lead you along. But ultimately, you have to make your own choices and your own decisions. So let me start with a story. This happened just like this over 30 years ago. A while back, a memory was created for me that even now brings pause for reflection. Dusk had reluctantly bowed to advancing darkness. An early evening congestion busied the admitting clerks in the emergency waiting room. The radio crackled. General Hospital, this is Rescue 12. We are en route to your facility with a 50-year-old man with difficulty breathing. He is confused with very weak pulses. He has terminal lung cancer. Over. Such a case led me to hesitate. Terminal cancer, expected to die, now in shock and gasping for breath. I thought and said, Rescue 12, assist ventilation with oxygen, suction the airway, evaluate constantly, and transport. I'll be standing by. The stricken man arrived a few minutes later, clearly dying, with glassy eyes, feeble pulses, lips drawn over bared teeth. Mr. Jones, I asked, can you hear me? He blinked painfully and replied, too weak to respond verbally. The daughter, a mature husky blonde, relayed to me the events of the last few weeks: increasing home health care, terrible pain, gradual inability to swallow, now gasping for breath for 2 days. He wanted to die at home, but we just couldn't take it no more watching him suffer, she said. A moment later, she went on, Doc, he didn't want no tubes in his throat. He wanted to go peaceful. I led the daughter, the wife, and a grandchild of teen years outside the examination room. In a few moments, Mr. Jones will die, I said. I can do various things that may support him for a day or so, but this will require tubes in his throat, IVs, and many tests, and it won't help him. He is so near the end now. I think we should just all go in and sit with him and just be near to him for his last few minutes. The family conferred for a moment. That's what we were praying for, Doc, whispered the daughter. These last few weeks, all we could hope for was that he could finally be at peace. He's been sick for so long. We returned to Mr. Jones, who was now staring dazedly up at the ceiling. His pulse had slowed and was very erratic. Slowly, his eyes met those of his wife, who was now standing by his side, holding his hand. His daughter and grandchild completed the circle around the bed, I remaining at his head to suction his airway, lest he choke on any thick secretions. He always liked to hear Amazing Grace, said the wife. Why don't you sing it for him? I said softly. Her voice was so full of tears that she could only murmur a cracked weep. But then her daughter began to sing, her own voice shaking and stumbling, and she sang, Amazing Grace, how sweet the sound. Mr. Jones visibly relaxed, his lids settling a fraction. All leaned toward him, all eyes fixed on his. That saved a wretch like me. The wife, gripping his hand tighter, said, You go on, honey. You go be with Jesus. His pulse slowed, and the breathing became easier and more shallow. And she sang, I once was lost, but now I'm found. Mr. Jones began to stare upward, and a haziness covered his eyes. His pulse only occasionally flickered. Only a wisp of air moved into his lungs. His wife said, You go on, honey. You go be with Jesus. Was blind, but now I see, she murmured. All was still and quiet for what seemed a very long time. Mr. Jones' eyes were fixed in infinity. His heart was still. We remained standing around the stretcher a while longer. After a bit, I pressed his lids down and I placed my hand over his sweet wife's hand. And I said, I'll be right outside if you need me. Closing the door after myself, I headed for the little office where I go to cry privately when my heartstrings get strummed. Sometimes I think as I weep into my handkerchief. This job just takes more out of me than I can stand. Who am I to pick a moment such as this to let a man die? Where is my authority? How did I know? Could I have been wrong? And then a trickle of a feeling from the recesses of my mind cooled my passion. All of us can only be what we are. In the great family of human brotherhood, the depth of our experiences, mixed well with a sincere commitment to decency, requires us to only do our best while giving the greatest attention to care possible. In this reality is the strength to go on. I turned from my thoughts of the dying to go out and care for the living through the long night that lay ahead. My own journey from a town west of Atlanta was that I was raised Southern Baptist, very Christian family. My parents were both Sunday school teachers. I'll talk about them later. And then I went off to Georgia and started studying the sciences, and lo and behold, I started to become kind of agnostic. I didn't know what I believed. And then I got into medicine, and then shortly after my medical training, I went into private practice, went home to practice medicine in my hometown. And I really became, frankly, atheistic for a long time. And that was probably 35, 40 years ago. And in that time, I've seen hundreds of thousands of patients. I have cried at the bedside with so many people. And I have taken a free rein to study really any subject, especially the study of the stars, cosmology, the history of the universe, and so forth. And I have found this journey to be a wonderful thing for me that has helped me really collect my thoughts here as I get older. For example, in deciding about having faith, look at the 7 billion people in the world. There are a billion Hindus. There are 500 million Buddhists. There are 4 billion members of the Abrahamic faith, such as Judaism and Christianity. And there are similar but contrasting features of what these people of faith feel. What I've tried to do is to take my path to understand if I can get some kind of indication from what the universe is like to help me with my own struggle for what I believe. Here's what the hard science shows, folks. That 72% of our universe is dark energy, which we have no idea what it is. None, zip, zilch. We have no idea what 72% of that which composes our universe is. This is a fact, which means what we do know is that apparently the dark energy seems to in some way be causing the universe to expand. This is called an open universe that should not crash back on itself and form another Big Bang some many billion years from now. 23% of the universe is dark matter. We have no idea what the dark matter is. It seems to have gravitational features, but we do not know what it is. It is not a proton, it is not a neutron, it's not a boson, electron, pion, meson, and so forth. We have no idea. And so only if you pinch yourself right now and you draw blood, that matter that you're made of and the stars outside and the table next to you, everything that we know in the universe, look up at the stars tonight, that is normal matter, including the stars, the suns that are burning, all the planets, the meteors, asteroids, and so forth, is only 4.6% of the stuff in the universe. What in the heck is this other stuff? And indeed, when you look at the history of the universe, that the nature of matter has changed. The dark matter during the time the universe was beginning to form, about 13.8 billion years ago, was about 63%, whereas dark energy now seems to be the lion's share of whatever it is that this stuff is. If you think that you know what all this is, you're fooling yourself, because the finest minds in the known universe, which is our Earth, have no idea what it is. We know some of the features. So why do I bring that up? Because when you get into issues of science, What science is about is using findings from research and testing to be able to describe findings and expectations. Findings are findings, expectations are theories. Well, of what I just spoke, which is the dark energy, dark matter, this is the most precisely tested theory in the history of science. Indeed, I just go on to the next slide, is that when you get into quantum theory, into the electron magnetic moment, this is tested with confidence to 0.28 parts per trillion. There is no other tested theory in the history of humankind ever before, which confirms what we were talking about a few months ago about dark energy and dark matter. So I have found on my path, not yours, that what I have chosen to do is to accept these findings as they've come out and as they continue to mature, because I choose to include that in my worldview. This is the Milky Way galaxy. This was taken by the Hubble photograph 385 miles from above the Earth, consisting of hundreds of billions of stars just like our own. And at the center of the Milky Way is an enormous supermassive black hole. If you were reading that the Nobel Prize was given today for Sir Roger Penrose, who was the discoverer of black holes back in the 60s. Einstein didn't believe that they were real, but Penrose, in fact, described that they were, in fact, real. I'm working my way through this book. I'm a bookaholic. Anybody who knows me knows that my office, my home, and wherever is full of books. I've kind of given up reading as I've gotten old, and I'm listening to audiobooks, and I'm working my way through this book, which is by Brian Greene, which is to the end, called Until the End of Time. Greene is a physicist, and what he talks about is from the very beginning of the universe into the far distant future as best scientific evidence gives us now. So what does he say? I'm going to refer you to this article, which is the timelines of the future. You can look it up on Google. This is, it's right there for you to look at. And following on to Greene's work, this is an excellent discussion. For example, here are hard estimates based on science of what's going to happen to our Earth 10,000, 15,000, 17,000, 25,000 years from now. 25,000, the northern Martian polar ice cap could recede as Mars receives a warming peak. By the way, look out tonight. The planet Mars will be at its closest approach to Earth tonight for the next 15 years. So if you want to see a nice bright red dot in the sky, you should look out in the sky tonight. But looking out a billion more years, our Earth, the universe started 13.8 billion years ago. The sun's been around about 5 billion, the Earth around 4.5 billion years. Unicellular life seemed to appear something in the range of about 3.7, 3.8 billion years ago. There's a whole discussion about how close to the Earth the moon was in those days. In fact, another planet, Theia, seems to have hit the Earth. You can look this up and you can validate that I'm not crazy. Exploded off the Earth and caused a ring around the Earth about 4 billion years ago. And the ring around the Earth coalesced into the moon. The Earth was turning in a 6-hour rather than 24-hour timeline about 4 billion years ago. And the moon was only 10,000 miles away. The Earth was turning at 4,000 miles an hour in those years. The moon was 10,000 miles away. The Earth was predominantly covered with water. A tidal wave, 1,000 feet tall, circled the Earth every 4 hours at 1,000 miles an hour. It was in that setting where life began on our planet. Very interesting. If you go on a billion, 1.1 billion, 1.2 billion, 1.3 billion years from now, but look at the very end of this article, and this is what Brian Greene is talking about in his book, that our universe is estimated to hang around to not, we are 13.8 billion years ago. That's 13 times 10 to the ninth. Our universe is expected to hang around to 10 to the 10th, to the 10th, to the 56. That's a long, long time based upon hard science. And so for me, in my path, I have chosen to try to accept that into my worldview. You make up your own mind because you must find your own path. If my talking about my faith and what I've chosen to believe in any way bugs you, I'm sorry. This weekend I sat, well, I'll tell you the story. I, I find that people's faith is no barrier to being able to be a part of my life, my existence, and my work. And I would encourage you to reflect on the same thing. But I'm not going to be around billions and billions and quadrillions and quintillions of years. I'm 67. My father made 83. My mother made 93. I'd like to split the difference. Let's make that 87. That means I got 20 years to go. Well, I'm an emergency doc by trade. I push on people's chests. I put tubes in their throats. I stick IVs and do all kinds of things to them. I don't want none of that stuff done at the end. And so what I would encourage you to look at is a website called POLST, which is the Physician's Orders for Life-Sustaining Treatment.org, where you will find this form where you, yes, you, can encourage your mother, father, your grandparents, those that are frail and elderly around you or who have diseases where they're expected to expire, to be able to write down exactly what they want. We make such plans about bringing children, bringing babies into this world. Ladies and gentlemen, we must make the same plans ourselves for the people we love as we near the end ourselves, not just to not be a burden, so that we can check out just as comfortably as we checked in, you might say. So I got to thinking, Brandon, Dr. Morchetti is with us tonight, and in planning my own future and believing in the stars that I do, I decided this is from my home in Georgia. This is the wine cellar in my home in Georgia, and the wine cellar is made of concrete. It's underground under the front yard. This is that photograph of the Milky Way that I showed you. I had an artist named Stuart Huntington come paint this. He was actually very Michelangelo-like. He was on a framework that held him up for about 6 weeks to be able to paint this. And this is essentially what a photograph of the Milky Way looks like. And yes, it glows in the dark, and especially under ultraviolet light. We live in the Orion arm of the Milky Way galaxy, nearly out to the periphery of the Milky Way galaxy. This is the Orion arm of the Milky Way galaxy. This is your fat old man, your buddy right here. And this is where my urn will go, right in front of the Orion arm, staring up at the Milky Way galaxy, because that's what I want to do to check out. You have to make your own decisions. Here's an example of a man who's made his decisions. This is going to be your reading assignment. Rachel, we got to figure out a way. Why don't, Rachel, would you please Google Atlantic Magazine, Francis Collins. It's from March 17, 2020. Get the link, put it in chat, please. And we'll also mail it out. This was a wonderful interview with the director of the National Institutes of Health. He's one of the smartest people in the world. Fauci of COVID fame helped hire him, but Fauci now works for this guy. And this interview is one of the most marvelous stories that you'll ever read. For all the bluster that's occurring in politics right now, he talks what's been going on behind the scenes on an international basis to make a vaccine. And it was so reassuring to read this. I urge you to read it. It'll take you 30 minutes. At the end of the article, he talks about the fact that he was a Christian when he was young. And then he became agnostic and really wandered in his faith for a while. And he explains about why in his latter years that he had, as one of the smartest scientists in the world, that he has chosen to have faith, in this case, a Christian faith. And I found it a very interesting read about how very intelligent people make informed decisions about their lives. And so then we come from the universe, from the stars to the earth to humanity, and how we will face humanity. Now, I actually am on Facebook a little bit. I track old girlfriends, and I'm on EMS Docs with Brendan, and I'm on EM Docs, Emergency Medicine Docs. And, there's a lot of chatter from docs of all age, from fresh out of residency all the way to my age. And a couple of weeks ago, a guy writes in and he says this. He says, I'm 8 years out from my residency. I'm just sick of it. I'm ready to retire. I'm tired of it. Who all is ready to retire right now? And you know how most of you know how Facebook works. Like 70 replies come, and so many people already wrote that they were ready to retire. And as I've mentioned many times, I'm on the admissions committee at this medical school. I interview pre-med students. In the time I've been on the committee, we have had applicants from 50,000 people, interviewing about 800 a year. And I listen to interviewers promising me that they want to learn an applied science so that they can enter into a partnership for healthcare so that they can better the human condition. So I know this guy, 8 years plus 3 years residency, that's 11, plus 4 of med school, that's 15. I know this guy 15 and a half years ago was promising an admissions committee member, a interviewer, that he happened to be that he was going to work for the betterment of the human condition and practice medicine. And now, 15 years later, he was ready to quit. And I go to myself, I say, what in the world did we do to this guy? And so many other people, so many young people said the same thing, that they were just ready to quit. What happened in those small number of intervening years? Focus on me for a second. Is that going to happen to you? Maybe not. I hope not. A guy wrote in on Facebook and he said, well, I've been out 25 years and I'm on a 6-year path to retirement, which means he'll retire at 31. So finally, the old man here, I wrote in and I said, well, you know, I've been doing this for 43 years and I love what I do. It is the most intellectually stimulating thing that I do. It's the most important social event of my life, especially right now with COVID. And I love working with people. And the people that I work with, Brandon Morchetti included, are the best friends of my life. And I know Brandon feels the same way. I'm working with people that I love and who love me. What a wonderful thing. Why in the world else would I want to do anything else but that? So what we're going to drift into now is as we think about patients, I'm going to give you several samples, a bunch of them. And are you going to enter into a partnership for healthcare by learning and applied science? Let's take some cases and just see how we would go about doing that. For example, this was a patient that came to me a few years ago. EMS had responded to the scene. The guy had a shirt on at the time. This was what's the politically correct term, non-domiciled individual. It was a homeless guy in a shelter. And it was freezing out there. Yes, it gets cold in Texas sometime. And he had eventually leaned on the heater and he felt the burn. EMS came. Apparently, they swore they didn't lift his shirt. And so ultimately, he made his way to the ER to see me. This is the man. Here, I will show you the 3 phases of burns, first, second, third degree. This is first degree burn here. Can you see this down here? Just the red. This is superficial second degree burn here. That's actually a little greater than superficial. Probably superficial second degree here. This is deep second degree. This is all deep second degree burn here. You see these little dots? These are called reedy pegs. And this is where the skin has been burned so deeply that it's almost all the way burned through. This thing has a terrible chance of getting infected. Skin grafts may be involved. The man managed to get his own ride to the hospital, and lo and behold, the same medics showed up at the ER a little while later, and we had a little prayer meeting in the office when I showed them what they did not bring to the hospital. Or as Brandon has been to West Georgia, this would be a funeral in my hometown in Western Georgia with the big mud tires. In medicine, folks, if you think it's going to be a breeze and that all of your patients are going to be sweet smelling, nice talking, polite, yes or no, sir, paying their bills and so forth, you've got another think coming. Moreover, there is a federal law called EMTALA, which is the Emergency Medical Treatment and Active Labor Act, which if you're working in a hospital in any way around emergency, in the emergency environment, you have to see the patients. You have to, by law, or the federal government will come in and shut down the hospital, and all 1,000 of its employees will be out of a job. So there are going to be some patients you're going to see along the way that you may not necessarily you want to see them, but you have to. It, of course, depends on what kind of career you go into. If you become a plastic surgeon and you want to do facelifts and you do it in your office, then you can pick and choose and select your patients. If you're going to be an emergency physician like Brandon and me working in ER, we're taking everybody that comes in the door. For example, a 32-year-old Texas female walked into the ER with a headache and collapses and has her first seizure. And I go, what in the world? This is a new onset seizure in a young woman. And I had no idea what was wrong. So we start working her up and we start IVs. We give her medicines for seizure. We get neurology called. And then ultimately, we get this CAT scan of her head, which shows these little white dots. These little white dots. Do any of you, Brandon, I know you know what this is, have any idea what this is? This is actually tapeworms eating her brain. If you're going to eat food, you want to cook it all the way through. If you're going to eat something that's in the viscera in the stomach, don't eat it raw, because you may get tapeworms, and the tapeworms may get in your body and work their way in part up to your brain and cause a new onset seizure disorder. And you say to yourself, well, they had to know that eating really undercooked meat was a hazard, especially if it was pork. But it was a lifestyle that was chosen by the patient, and I am not allowed to judge. I have to evaluate, offer care, make recommendations, and then work with the patient as they live their life, accepting all, some, or none of the recommendations that I make. In this case, there's no way to move the tapeworms. The white things are actually the skeletons of old burned out tapeworm cysts. So these are not active worms themselves. I always wondered if the worm is in the brain right by the ear, could you hear it going and eating? I don't know. I always wondered that. But or the guy who was driving carelessly through the mountains and this deer went plowing through the front of his SUV. Or the guy who was driving quickly through the streets and managed to get this plowed through his windshield. All were injured, all did stupid things, and all of them, we have to treat them with love and compassion. Like the young mother who brings her 2-week-old baby to the ER, who brings her 2-week-old baby to the ER who is not eating right. And she brings this infant and puts it in the nurse's hands. So all of you, I want you to look at this infant. What do you see? See what you see. Well, the kid's eyes are open. His mouth is open a little bit with his tongue protruding a little bit. I don't see any mucus. The ears are there. There's already hair. And this kid that's probably just a few weeks old, I can't see his bottom, so I don't know if it's a boy or a girl. But what else do you see? The baby's skin is pinkish blue. Can you tell? This is called cyanosis. This is a baby that was born with cyanotic congenital heart disease, resulting in blood bypassing the lungs, going from the right side of the heart to the left side of the heart. This kid is going to require cardiac surgery of some sort. And here's this infant put into my hands, and we have to be the ones to think rationally with this little kid? Yeah. So what do? You, as you approach the learning of the applied science, will learn the pathway of evaluation, which is called ABC. It is airway, it is breathing, it is circulation. Cyanotic means blue. Blue babies, think ABC. Is there something wrong with the airway? Does the kid have a marble in its throat? What about the lungs? Does the kid have pneumonia? Or is it something wrong with the heart, such as it was in this case, congenital heart disease? And of course, then I had to go tell the kid's mother that the kid is sick, it is serious, and we're bringing in a pediatric cardiovascular specialist to take care of the child. Many tests will be run to try to identify, is it a foramen ovale, or is it a septal hole in the septum in the heart, or what other problem is this that is causing this problem? But we in medicine, when we are taking care of patients, we are not the patient. We have to think rationally for the patient. Or this guy was a patient of mine, came to Parkland many years ago. This patient was actually transported by a friend after he was stabbed in the chest. Here is a man in shock who has been stabbed on the right side of his chest, who is laboring to breathe, in shock, whose pulse is very rapid. His oxygenation is very low. This guy is about to die, and we have to think rationally in an orderly manner so that we can give this guy what he needs, which is a decompression of this tension pneumothorax, excuse me, of this tension pneumothorax that you see right here. So we can then put a chest tube into the patient's chest so that we can re-inflate the lung. We have to think rationally, even times when a patient is desperately ill. It is also very important, ladies and gentlemen, that we must not criticize. It is not your place. You're not allowed to. You can offer your opinion, but criticizing people is going to hurt their feelings. You should not hurt the feelings of your patient. You take this guy. These are distended neck veins on this patient right here. This guy has smoked himself 2 packs a day for 60 plus years and has horrible emphysema. He has done that to himself by choice. He has destroyed his lungs, and now late in his life, he is laboring to breathe. He is constantly feeling a sense of smothering. He is permanently, horribly disabled and comes to us because he's very short of breath. And we hear the story of his 60 plus pack year history of smoking cigarettes, and it is not our place to judge. Our place is to love and support and to honor them where they are so that we can render both physical aid by way of the practice of medicine and spiritual aid by way of supporting them and helping them through a difficult time when they are terrified.
Dr. Fowler.
Or, yes.
Quick question we have in the chat. Would you say
Sure.
that it is experience and training alone that allows physicians to think rationally in these situations? Or do you feel that you have to have a certain personality to really succeed in this field?
Brandon, what do you think? You got your mic on?
Yeah, I'm here. It does, personality does matter, but there's a reason why these residency programs are years, because they expect you to see thousands and thousands of patients. And so that's where the experience can teach you what your personality may not have given you in the first place. And it really depends on what specialty you want to go into. So for example, Dr. Fowler and I are a bit more biased towards emergency physicians because we are trained to be even more rational and calm when everyone else is running around screaming and yelling and crying and people are dying and blood's hitting the ceiling. So it's something that in 3 years at Parkland training and residency, I probably saw 10,000 patients, and that's where the experience comes in.
And there are many specialties in medicine. Just look it up sometime. Google medical specialties and look at the many dozens that there are. I think it's 70 plus. And Brandon and I are down in the ER together frequently in Parkland, and we'll hear the code blue alarm go off. We don't respond to codes from Parkland, so it shouldn't even be going off in the ER. But it goes off anyway. It'll be like 14th floor code blue, meaning someone's had a cardiac arrest up on the 14th floor. And Brandon and I look at each other and we know perfectly well that there are people with tight sphincter tones on that floor because they don't do this stuff on a regular basis. This is not what they do. They start IVs, they change dressings on wounds and so forth. And so it is certainly true that it is training and it is experience, but it's also, Brandon, I think you would agree, it's also good mentors
to be around people, to watch how they think. Folks, I have learned so much by being around people that are good thinkers. And you must find those people as you go on to school in your career. The slide you're looking at here was a patient I had at Parkland many years ago, who was a cop who was shot in the chest and who was desperately ill. And he was in deep shock, in and out of cardiac arrest, and absolutely near death. The best of the trauma team was taking care of him, and they were doing everything that they could do. And so for the moment, I stepped outside the booth where we were working on the patient, knowing that this was a cop. He'd been shot in the line of duty. I just sort of looked up, and in my formerly agnostic, atheistic, believing in the universe mind, whatever it is that I believed in, I said, "Oh God, please spare this man." And believe it or not, he got a pulse back. They were able to get him stabilized and at least get him to the operating room. So I don't know if it was the prayer or the skill of the surgeons or all of the above, but at least that was a moment in my life. And then the guy that shot him, the cop had one bullet in him. The guy that shot him had 17 bullets in him, and he was still alive. And we took care of the perpetrator. We took care of him in the room next door to where the cop had been, with the same skill and the same acceptance of humanity. Also with the guy handcuffed to the stretcher, so that we could start an IV on him and give him what he needed, so that later on he could stand trial for what he had done to that cop. Or the victim of elder abuse and the perpetrator. How do we handle those things? How do we not be judgmental about the perpetrator, but rather try to be instructive and lead the way toward rendering some care, evaluating and managing the elder, who in this case, you see the term blue under the skin is called ecchymosis. You see the ecchymosis around the eye. If you look here, this is a skull fracture. The blow is here and here. It's caused a skull fracture with bleeding into the orbit. But we can't be judgmental. We have to be practical, and we have to be definite about what we do. Speaking of forgiveness, this was a patient I had at Parkland many years ago, who was cleaning a 30-06 and had it pointed down to his foot and hadn't taken the time to unload the gun, or at least he didn't realize that he hadn't unloaded. And so this is what happens when a 30-06 high-powered rifle bullet goes barreling through your foot and out the underside, through here and out here. Yes, that is foot guts right here. That is actually a flexor tendon, folks. And you don't go in there and say, "You stupid, what were you thinking?" You just go in there and say, "Well, let's figure out how we can help you, and let's hope that next time we unload our guns before we start cleaning them." Or simple kindness wherever we can render it. I could let this guy who has a nail through his thumb, can you see that right there? That is a power-driven nail through his thumb. I could let him go over to X-ray with that nail still in his thumb, hurting like the dickens. Or I could do what I actually did, and I took a needle and put it right here and right here, right here and right here, and I injected it with lidocaine, Novocaine, which did what's called a nerve block. And so the reason this sweet young man is smiling is because I have numbed his thumb up, and now he's not in any pain. And we can try to work on getting that nail out. You probably don't know this. It's actually very hard to get a nail out from a bone, because it is driven in and it is solid. It typically has to go to the operating room. Or being observant, because we must. Here's a kid with a head injury, teenager, and you see this blood here, right? In his ear, there in his pinna, which is the external ear. And some of that blood has dripped down onto the sheet, down right here onto the sheet. And what do you see? Well, you see red blood here, but then you see this clear stuff. What is that clear stuff? That clear stuff is cerebral spinal fluid. This is a thing called the ring sign. And what happens is that this young man has a skull fracture. And whereas I might have thought it was just an ear injury, in fact, he has a skull fracture that is broken into his middle ear cavity. Oh, this young man I had one day, he came in and he wanted to get his scalp fixed. And I said, well, okay. And so I look at this thing. And so what do you all see here, folks? Well, I see a cut, and it's about an inch long, inch and a half long, maybe. And it seems to go down through the skin right here, about an inch and a half long, goes down through the skin, but it seems to be a simple, fairly straightforward scalp laceration. So why should I worry about that? And the answer is that you have to ask what happened, or otherwise you will miss something important. It turns out that somebody went to kill this kid, to shoot at him, and the kid ducked and was shot at with a .357 Magnum bullet, and the bullet just creased his scalp like this. If this had hit him in the forehead, it would have blown his head wide open to pieces. So you've got to ask what happened and take an appropriate history, as well as history of present illness, in addition to performing the appropriate physical exam as well. Or this family that brought this child into me many years ago. Here is a baby that crawled too close to the propane stove in a home and has these deep second degree burns, deep second. These could be getting close to third degree here, probably deep second here. This could be some third degree, possibly here. And you want to say to the parents, what were you thinking? Why was the stove on? But parents can't be on guard 24/7. We must not be judgmental. We have to take the patients where they are in the scenario where it occurs. We have to love them and respect them and get them the care that they need. Now, I would probably activate the Child Protective Services just so that they could go to the home and put the parents through some remedial training about the care, about how to be careful with their infants. Or, if you're going to shoot up heroin and you find a hole that really works, shouldn't you just keep on using that one? Yes, folks, this is a heroin addict who, yes, kept using the same vein over and over and over again. We see enormous amounts of drug abuse. Anybody in the emergency room in any ER anywhere does. Brandon and I work in an inner city hospital, an urban level 1 trauma center, burn unit, cardiac center. And we see folks in all walks of life with every single drug. And so this is what a heroin user looks like, who has really gotten himself in a lot of trouble. And so this is that patient who, this infection here, this is not sterile, folks. This is full of, I like to call it Godzilla bacteria, all kinds of bacteria, which then get into the bloodstream and go back to the lungs and create lung abscesses here, enormous lung abscesses. This guy is very close to death. And we're going to treat him. And not only does the bacteria go to the lungs, it also goes into the heart. The tricuspid valve sits right there. The mitral valve is over here. Pulmonic valve here, and the aortic valve over here. And so these folks commonly, not only do they have lung abscesses like you see here, but they also commonly have heart valve infections as well. And so are we going to treat these folks? Give them hundreds of thousands of dollars of medical treatment with antibiotics, and even replace their heart valve if their heart valve is rotting off because they've destroyed themselves, and they can't even promise that they won't do it again? Are we going to treat them? The answer is yes. In other nations, it may not be so. In England, for example, with national health care, it might not be. For example, if you need a lung transplant and you were a chain smoker and you couldn't prove that you would quit smoking, you might not get your lung transplant. But yes, we're going to treat this fellow. We're going to give him all the high-powered antibiotics it takes, drain abscesses where we have to. We'll give him a new heart valve, and then hopefully we'll be able to surround him with the care that will keep him from relapsing. and be able to move on to a different phase of his life.
Dr.
For this,
Fowler,
yes.
we had a question. For patients who, hurt themselves with drugs and whatnot, do you recommend them to a rehabilitation center? Like, what kind of care would you provide to patients like that?
It's a great question. Brandon, I want you to pitch in too. I'll start. We absolutely surround people with all the resources that we have. Brandon, see if you agree with this. Certainly, one of the top 5 worst problems we have in medicine today is sufficient resources to deal with mental health. We got cardiac, we have stroke, we have trauma, we have burn, we have pediatric, we have neonate. But having enough care to be able to surround people with the strength that they need to be able to draw so that they gain their own strength can be very difficult. We get social work involved, we get psychiatry involved, and we try to get them resources. Folks without the ability to pay often don't have resources, and so we may be looking very hard for a place. And Texas, just 2 or 3 years ago, shut down 200 psychiatric inpatient beds in one of the hospitals south of here, which caused us a world of hurt there in the emergency room. Brandon, you want to comment?
Yeah, at Parkland, one of the benefits of being a county hospital is that we're supported by a lot of tax dollars. And we also are responsible for some of the healthcare throughout the Dallas County, over 2 million people. So our social workers are absolute gold in the ED. And whenever we see patients that have problems with, recurrent or, kind of falling off the wagon with multiple episodes of drug or alcohol abuse or dependence, our social workers, they're great with these patients. They get them plugged into these outpatient resources. In the pre-hospital setting, we also play a role. And when it comes to these mental health crises, we help to write protocols and supervise and do quality management for a team that includes a police officer, a social worker, and a paramedic who respond to behavioral health crises and emergencies out in the community. And the whole goal is to divert these patients away from jail or the ER. They don't need police to manage these. They need social workers to get them plugged into the right resources. So the police are there for scene safety. The paramedics are there for doing a medical screening evaluation. And the social workers are there to do what social workers do. And that's get patients exactly what they need that comes from our tax dollars.
Absolutely. And I was working with an EMS agency today about on every mental health thing that cops respond to, should we also always be sending a paramedic out in an ambulance with those patients as well? And we don't exactly know the right answer to that. What about the patients who smoke themselves to an early grave? I already showed you that awful case of emphysema. Here is a woman who has smoked herself many, we call them pack years. How many packs per day for how many years? Many pack years of smoking cigarettes, who now has a giant lung cancer. This area here should look dark, just like that. This is a giant lung tumor that is sitting in her right lung. This is right side, this is left side, that is now spreading out to the periphery of the lung, probably up here some as well. This is a terrible problem. It's probably not treatable. And this person is going to die a death where this cancer spreads all over the body, including to the brain. And our job is to support the patient, to give them everything that we can give them, including our strength, our interpersonal support. Pray with them if they ask you to, with the full understanding that what we're doing is making them more comfortable, making their spirit more comfortable as they face a very, very difficult problem. Now, don't tell me the seatbelts don't save lives. This is a patient I had at Parkland many years ago who was in an automobile accident. It was a terrible high-speed collision rollover. And you know this came from EMS because this is the splint that was placed on by the paramedic in the field. This, folks, is a horribly fractured pelvis. This pelvis is broken here, 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 here. And everywhere where there is bone, there is blood vessels. There is also a dislocation right here. I know you can't see it so well. This joint here should be as wide as that joint right there. This joint is quite wide. I know you can't see it all that well. This is a fractured dislocation of the pelvis. The pelvis is full of blood vessels, and when the pelvis breaks, the patients begin to bleed to death internally. This patient, in fact, arrested on the CAT scan table. This patient is actually on the CAT scan table, not in the operating room where this particular surgeon is. They cut him right there on the CAT scan table to try to get in and cross clamp his aorta so that the blood supply to the pelvis would stop. Here is another picture where they're reaching inside, and this is the cross clamp that is on the aorta right here. Sadly, unfortunately, in spite of this patient was injured too badly and we lost him. Excuse me. I took this picture right after that event of the room where the young man had been who was in the car accident with a broken pelvis that we sent off to CAT scan. I want you to look at this picture. Every single thing in this room, every dot, every IV bag, every syringe, every IV bag, every wrapper, and so forth, everything on the floor here was an independent activity to save this man's life. This many different things happened in the space of minutes to try to save this man's life. And in spite of doing all that we could, we lost it. Does it wear and tear on us? You bet. It most certainly does. We put our heart and our minds and our energy and our prayers into it. And very often, in spite of everything we do, it's just not enough. The patients are too sick or too badly injured. This is something that you're going to have to think about as you get into medicine, that how you are going to deal with tragedy. People either come to us for checkups, for preventive maintenance, or they come to us when they're sick and not having a nice day. We have to stand in between people often and death.
Dr. Fowler.
Yes, ma'am.
So some of our members had questions on how you maintain your mental health, seeing so many tragedies so far in your career. Also, Dr. Salazar is in the chat in the call right now.
Well, welcome, Gil. I'll start, and I would love for Gil and Brandon to comment as well. I'm a single guy. I never got married, never had any kids. I got married to medicine about 47 years ago, and she's a jealous mistress, but I keep coming back. It's a composite of issues. I will say that this year, this 9 months with COVID has been weird because I'm alone here as I am right now in my apartment. And, you know, being alone a lot is weird. You can only do the internet and watch so many reruns of Law and Order and all that stuff. And so it's very important that one finds those pathways that it takes for mental health. One of the ways that I maintain my mental health is that I'm working in a place where I really enjoy the people. Gil Salazar, who's spoken recently, Brandon Morchetti, who's here with us tonight, who spoke in the past, two of my best friends in the world. We all, the folks that work around us are exceptionally supportive, and we work with staffs that are very supportive. By and large, most of our patients really appreciate what we do for them. And so part of what keeps me going is that it's a little like getting water from the well, is that I get strength back from the patients who say thank you, and the patients who now understand where they didn't understand before. How about you, Gil? Are you there?
I'm here. Good evening, guys. Good seeing y'all.
How do you maintain your mental health?
You know, I've spoken very often about the balance of work and life. All right, here. I am now in a lighted place. I talk about the balance of work and life, but that's going to have a very specific meaning. And so I've taken that to heart. And to me, work and life balance equals mental health. And so I got three things that I constantly cycle that keep me mentally healthy. That's my work, my family, and my mental and physical health. So when I achieve a good balance of those three, that really, really helps me stay vibrant and do my job well. When one of those aspects takes over the other for whatever reason because it needs to be that way, then the other two got to balance each other out. So that is the one single way that's worked for me, because the kinds of things that we do and see on a day-to-day basis are scary sometimes, and they wear on you. And it's a lifetime commitment to maintaining your mental health, your body health. So that's exactly what I do.
Thank you, Gail. Brandon, how about you?
Yeah, I like to think I'm a pretty simple guy to please. And for me, mental health is usually improved, like you, just with a simple bit of gratitude. I find value in my work. So if I feel like what I'm doing is important and I'm making a difference with my patients or in my community, which is really why I like EMS, because I feel like I can amplify what I do, then I feel empowered and energized to keep going. That being said, sometimes this job is a beatdown, and you get a string of several shifts in a row where things aren't going well. Maybe you're not a great doctor, patients hate you, cussing at you, kids aren't happy. I'm a parent of a teenager, so usually no shortage of drama and strife under my roof here. So sometimes I'd rely on my wife to smack me around and keep me in my place and take me out of town on vacation and stuff every now and then. So. We're going to Jackson Hole and Yellowstone next week, as a matter of fact. So I'm going to work
That's
on
what you need to do.
I'm going to work on my mental health next weekend.
Exactly. Beating your way up a mountain. Yeah, go ahead.
We actually had another question. So
Sure.
some students wondered, how do you deal with seeing all these gruesome images and injuries? I think you ruined a couple of people's dinners tonight. I think someone was cooking raw chicken when you were mentioning tapeworms.
Well, you want to cook your chicken all the way through, okay? You don't want to hear that chewing sound in your brain. So how do you? Well, we're applied scientists. We are body mechanics. We deal with the human body. The human body is not just what it looks like on the outside. It has millions of components, trillions of cells. And so we are accustomed to the innards of the body. We see it all the time, whether it's a compound fracture of a tibia that's poked through the skin, or a guy with a busted pelvis, like I showed you, that we have to crack his abdomen right there in the CAT scan suite so that we can try to resuscitate him. And so forth. This is part of medicine. You know, I'm the kid that in the fourth grade, right after lunch, when Elaine Barnett one time vomited fourth grade, I was 10 years old, puked all over her desk, I immediately started puking. I would never have dreamed that today I will sit there and hold the head of a puking patient and I'll hold the bag for them like this. I'll say, all done, wipe them mouth. Okay. You know, it's just, you get used to it. Let's move on, Rachel. We'll get to the questions part in a moment, okay?
Mm-hmm.
This was one of our earlier residency teams about 15 years ago on top of the old Parkland ER. Sorry. Here we are now in an era where super spreader clustering has never been more important than it is today. As the COVID continues to spike upwards, we've had a spike upwards in our patient flow here in Dallas. According to the numbers that we saw today, we have almost 1,000 patients in the region in the hospital with COVID. This is almost half again what it was about a month ago. And so we have an obligation to try to get the word out to the public about not having these spreading events. But so many events of the news of where people render harm to other people, we're on the receiving end of trying to resuscitate these folks. Or storms that come through and make absolute mincemeat of like Hurricane Katrina that hit New Orleans back in 2005 and caused 400,000 people to leave the city, many, many deaths associated with that. Or when I was in Tokyo, reflections of March 20, 1995, when this actually is that you see the Japanese language there. This actually is the Tokyo subway where the sarin nerve agent attack occurred by the Aum Shinrikyo cult, killing many and poisoning many, many people, this harm that people do to others. Also, when I was in Japan, I went to Hiroshima, and this is in the Hiroshima Peace Museum. And this is what downtown Hiroshima looked like before 8:15 in the morning, on August the 6th of 1945. And the B-25 bomber, the Enola Gay, from 30,000 plus feet, aimed at this bridge right here as the bullseye point of the fire. And so here again, notice that Hiroshima is a city of rivers. You can pronounce it Hiroshima if you want. Hiroshima is what I actually heard. Hiroshima is fine. And so this was the aiming point of the bomb when a 10,000 ton equivalent of tons of TNT bomb was exploded. This is an actual photograph of when it happened at 8:15 in the morning. This was a photograph taken by a Japanese citizen of the bomb itself from Hiroshima. This is this is a homemade photo by a Japanese citizen that had just been bombed. Very interesting. And at 1,800 feet, a fireball showed up above the city of Hiroshima. You see these mountains all over. The mountains concentrated the fireball, destroying the city, killing tens of thousands of people, ultimately resulting in over 100,000 deaths. This is the ruin of the Hiroshima Prefectural Industrial Promotion Hall, which is now the atomic bomb dome. And I saw all this up close and personal. And here is actually a map of the damage that was done. The red part is a part that was totally wiped out by the bomb. This is something you probably have never seen before. The night after Hiroshima was bombed, an artist crawled up onto one of the mountains overlooking Hiroshima and painted what he saw. This is an artist's rendering of what Hiroshima looked like the night after the bombing. The city was on fire. These were the rivers going through the cities. The burnt and the dying ran to the rivers and jumped into the rivers for relief. And I show this picture. Here was downtown Hiroshima where it was bombed. The lines here, the broken lines here, excuse me, are the evacuation routes that people took out of the city to go to other cities to try to help them. Indeed, there was one I know, Japanese citizen that actually was bombed on with both bombs. He was bombed on in Hiroshima, survived, went to Nagasaki, where 3 days later the next bomb was dropped, and he survived that bombing as well. And so we're going to have to continue to face, as citizens of the world, the universal problem of fighting with each other while at the same time we're taking care of one patient at a time. And yet, a little boy came to my office one day because he couldn't stop crying. It seemed that this little boy's father had been buried that day. And at the funeral, the little boy had begun to cry hysterically, sobbing loudly that he wanted to die too, to go and be with his father in heaven. This was more than his mother could bear. So she brought her son to me. Entering the room, I looked at the pair, both consumed in their grief. Dr. Fowler, could you give my son something to calm him? He's so upset about his father's death that at the funeral he said that he wanted to die and to go to be with his papa. Some things I can handle just fine. Blood, gore, cuts, fractures. These things are no problem for my sensitivity. But people's sorrow, their grief, especially the shared sorrow among family members for a lost loved one, is so hard for me to deal with at arm's length. My heart softens quickly at the sight of a family member who has lost a part of their minds, a part of their very lives. Sooner or later, I had to look the little boy in the face. His eyes were wide open, reddened from his sobbing only a few minutes before. He seemed dazed, his gaze glassy and his cheeks tear-streaked. "I'm so sorry about your dad," I said. He didn't say anything for a moment, only nodding slowly as his eyes filled again with tears. Then I leaned to him and held his hand for a moment, unsure of the relevance of anything I had to say. You know, sometimes God loves a few special people so much that he wants them to come live with him in heaven. I whispered to him softly. My own eyes now filled with tears. My voice cracked after that, and I couldn't speak. Sorry about that. You'll be with him tonight? I asked her mother. She said that she would. At this point, my nurse appeared at my shoulder. I murmured to him to give the little guy an injection of a mild sedative, reassuring his mother that I felt that this was an understandable anxiety reaction that would pass. I turned my back on the pair and went to the next patient. Several days passed. My practice kept my thoughts turned to healing matters of all types. The little boy and his sorrow were forgotten for the moment. Then an evening came in my ER when it seemed like most of the people of my county had the flu at the same time and had come to see me all at once. The rooms and the halls of my clinics were filled with the moans and groans of misery. Emergency medicine is a unique breed of patient care. I must move from room to room constantly, seeing what I see, analyzing data continuously, forming impressions of the people and the problems that I confront. My nurse stuck a chart in my hand and indexed me to the next curtain. Brushing aside the curtain, I entered the cubicle. There was the familiar scene of a mother and daughter, the little girl coughing and feverish. A routine exam followed and medications were prescribed to deal with the problem. As I leaned against the counter writing the prescriptions for the little girl, his mother walked softly up to me and quietly said, I only had to give him one of those pills you prescribed, referring to her son who'd been in the room with her daughter while I was examining her. I nodded, my thoughts engrossed in the mechanisms of disease and of the patients I had yet to see. He was fine the next morning when he woke up, the mother offered. Great, I exclaimed distantly. He said Papa came to him during the night, and after that, everything was all right, she concluded. Remembrance flooded my mind as that little boy's face from the week before with the tears and the red eyes melted into the smiling features of this little boy in the back of the exam room with his sister. What did you say? I asked a little too sharply. He told me the next morning that his father had come to see him during the night. He'd been sick for so long and in the hospital. He had had all those tubes going in him, and he had been so uncomfortable and in such pain, she said. When Papa came to him in the night, she said, he wasn't sick anymore. He was wearing a long white robe and was surrounded by a golden light. He told my son that he wasn't in pain any longer and that he felt well and strong. These sorts of stories paralyze me, with tears springing to my eyes and my heart just pounding. The mother went on, and at the last of his dream, Papa said that he loved him and would always be with him. When my son woke the next morning, he was fine and he was not sad anymore. My mind was reeling from this story, so rich and personal, so cloaked in the hazy matters of the supernatural. I turned to the mother and saw the peace in her heart that the event had brought her. And then I turned to the little boy, who had an ear-to-ear smile which wreathed his face in childlike joy. And I gave him a big hug and a kiss. And then I sent them on their way and excused myself to an office for a few minutes to dry my eyes before returning to my patients. So, Rachel, let's pause for a little questions for a few minutes.
Goodness gracious. A lot of students are expecting a book from you and also that you narrate this whole book. So you just have a great voice to tell your stories. Okay, questions. How do you differentiate a difficult patient who knows something is wrong and doesn't feel heard?
That's a great question. It is so important to listen to the patient part of what we do in medicine is that we have to listen. We also have to weigh the scientific facts in front of us. I invented a new sign recently. I named it after one of our residents, Dr. So-and-so's sign. And what the sign is that if a patient comes and sees me with horrible abdominal pain and pain in the belly, and I can't really explain what their pain is, and I find that they've had 15 or more CAT scans of the abdomen in the last 10 years, then the pain is almost certainly not organic. It is probably psychological in nature. But I only reached that point after using applied science, which means that we have to talk to the patient. We have to examine them, order appropriate testing, so that we can do the best we can do to determine what we think is wrong with the patient. So it's both parts. It's listening, and it's important to make the patient feel like that they are heard. Patients occasionally don't want to hear what you have to say. I got sideways with a patient a few years ago who was claiming that a rash that she had was one thing, and I did not at all feel, based upon my experience, that that's what it was. And she felt like I didn't hear her, and it annoyed her. And I'm sorry about that. I was entitled to my scientific opinion, but she just didn't want to hear it. What's the next question?
How do you step outside of a patient's point of view, especially if you find yourself in a situation or with a patient you feel strongly about? As future providers, how can we begin to move away from judging others to make ourselves better care providers?
Well, I'll take the last part of the question first. You have to find that strength within. Many people are born wise. It was said about President James Madison that he reached wisdom at an early age. That is from the book Miracle in Philadelphia, which is a very interesting read. But most normal people, and I would be sort of one of those, have to grow up and grow into it. And so you will find that you won't know all the answers early. And you're going to spend an enormous amount of time studying and working to gain the specialty, whether it's family medicine, like we heard a couple of weeks ago, or whatever specialty, to be able to learn that. I think beyond that is that it's just going to be very important that you continue to work and you continue to study. And in this era of the smartphone, you are surrounded by every fact. So there's no excuse for not looking things up. Next question.
As a physician, how do you manage to sympathize without being overwhelmed with emotions and it getting in the way of your practice?
That's a great question. In both those stories I told you tonight, that I went down the hall to cry. I've occasionally cried with patients, especially when I was a lot younger. I've just been around a lot of people. I've been around a couple 100,000 patients now, and so it's different. You know, I've been through an enormous amount of emotional content. And so, and there is a thing called maturity. There comes a time in your life when you can step back and look at your own feelings. This is true, and this is called maturity. And some might argue it, but finally, as with approaching old age, I think I've gained some ability to step outside myself and be able to assess my own feelings. It is exceptionally important, ladies and gentlemen, that you not become emotional during the care of a patient. You can become emotional afterwards, after the care is done, and you can sit with the family and cry along with them. But if you're in the middle of care, you can't do that. So, and this maturity comes with the passing years.
Another question students have is, how do you, or have you ever needed to choose between patients to treat? How do you decide who gets treatment or who doesn't if there isn't enough staff/time to treat both?
Well, that's a great question. This afternoon, I met with the Mass Care Committee here in the Dallas County area, which is a document we've had to create as a medical community to determine what happens if all of our ventilators are being used here in our COVID epidemic, and we have 2 patients that come and we don't have a ventilator to go around. How do we make that decision? And so that's called a mass care document. The answer is that you get enough help. You get the, in the case of a hospital, you would get the administrator and legal of the hospital involved. If it's an issue of having to make such critical decisions about care. Now, if the question is that we're in the ER and we are so darn busy that I have to decide which of two patients that I have to go treat now, then I'll do what's called a triage, because you can do a lot by looking at a patient in just a matter of 15, 20, 30 seconds. And if a patient is eyes open, they've got a radial pulse, and they can protect their airway, and they're not having spurting arterial bleeding. And whereas the guy next door is not talking at all, his eyes are closed and you can't feel a pulse, you probably need to go there first to the guy without the pulse, for example. So this is called triage, and we do it all the time. It starts in the waiting room of the hospital. It starts in the field with Brandon and his team and EMS, and we try to determine which patient needs our services first. It's already 8:16. Why don't we take one more, because I got about another 20 minutes, and then we'll do the rest at the end, okay?
Okay. So obviously some of these patients and their stories have touched you and like have made an impact on your life. So some of our members have wondered, how involved can you be in your patients' lives to like help them out, to be a support for them?
Well, I practiced medicine for a long time in my hometown. I was actually like Dr. Luna that spoke to us recently, which was a wonderful talk. I went home to practice medicine, so I was very close friends with a lot of my patients because I'd grown up with a lot of them. In my work here as an urban trauma center, my relationships with patients here are by and large mostly casual, unless they were referred to me through a friend. A friend of mine who happens to be an attorney referred a family member to me who had a problem with a back. And I took care of the person and got them referred in to a neurologist. And so this was someone that I knew and could be cordial with. But by and large, in my world of emergency medicine in a level 1 trauma center, the relationships with patients tend to be a bit more casual than they were when I was working in a small town. Dr. Luna, who spoke to us, went back to the town where he was born and treated people from crazy. And he was known on the street as he walked by. So, which is a great thing. Okay, well, we'll do a few more minutes and then we'll take the questions at the end. One of the things I wanted to cover is about breaking bad news. And how do you do that? You have to really know your stuff. Right now, for those of you that are new to medicine or maybe just getting started or haven't started yet, you may not have the confidence that one day you're going to be able to have enough smarts to know what you're talking about. Trust me, you will. It's a lifetime of study. If there's something you don't know, you have to look it up, but you will. You'll be confident about that. And then you can hand them the tragedy a teaspoon at a time, as opposed to just breaking the news all of a sudden. You could say, I have to talk to you about something. Do you want me just to get to the point? Or you could say that, but I don't. I tend to break the news a little bit at a time and then be prepared to answer the many questions that are going to come. Doctor, is he going to die? Doctor, what will happen to him? Doctor, what will happen to me and the baby? And so forth. And so when we then deal with suffering patients, we deal with them on the physical level as a physician, nurse, PA, and so forth. We also deal with them where they are in their emotional state, not becoming emotional ourselves. And then we try to deal with the social element as well. For example, if something terrible has happened, for example, the old lady who the elder abuse, I clearly have social issues that I got to deal with to help get this lady placed in a safe environment once she is okay to go home. So, for example, I had a patient recently who came to see me because she was a youngish adult woman who came to see me because she'd been having a headache for several months.
And then for the last few weeks had trouble word finding. I'm trying to think of, what I'm talking about, that word here. She was having trouble word finding. And then in the last couple of days had weakness in one of the extremities. I examined her, and the family was there. And as part of the workup, we did this MRI scan here together with a neurologist. This is a brain tumor. This is the normal ventricle where cerebral spinal fluid lives. This is a brain tumor that before they came to see me in the ER, they did not know that she had. This is cancer of the brain. This is a very nice lady with a very nice family who was minding her own business and develops cancer of the brain that may well be her death. This is the same cancer that the former Senator John McCain from Arizona had, that took his life as an old man. And so I chose to break the news to her quite slowly that, that we found something here. I'm concerned about it. I'm going to have the specialist come see you, and we probably will be running some more tests, and I'm going to put you in the hospital and make you comfortable and take care of your pain. As Brandon knows, this is a midline shift of the brain. There's so much pressure on this side, it's actually shoving the brain in this direction. This person was actually quite sick. I did take the spouse aside and go over this scan with the spouse to say, this is why this is so important. He cannot go home. We have to deal with this. Or this gentleman that came to see me with a cough, and we did a routine chest x-ray, and he was pretty sick, and he seemed to have a little markings right here, but I really didn't see much otherwise. Maybe something there, but not much, but he was pretty sick. And this was at the beginning of the COVID era, and we were doing a lot of CAT scans. So I did a CAT scan on him, and this is a CAT scan of a patient with COVID, and this is what COVID lung looks like. This is a consolidated lung, precipitated, if you will. This is air, and this is mucus and pus in this lung. And so I had to tell this man that he was really quite ill and that we had to put him in the hospital into intensive care. Or I had a patient come to see me, a young adult come to see me with an odd pressure sensation in their butt area, which they could also feel in their abdomen. And I really couldn't see much. So I did this CAT scan of the patient, and I found this beer bottle here inside his bottom that didn't belong there. I asked the fellow about that, and he said it was a complicated circus balancing routine, and it was just an accident. I said, okay, well, sure. And so we took him to the operating room to take that out because we could not retrieve it through the portal by which it had entered. Let me say that it is important not to laugh, not to smile, not to be judgmental, and just to be confident that we're going to help the patient take care of their problem. Or this young adult woman who came to see me because she had vertigo. Vertigo is the sense of the room spinning around like this. And she was really pretty uncomfortable with it, and it was new in onset. She never had it before. She didn't drink. She didn't do drugs. She was a working person in the working world. And and I was just concerned about her. And also, when she closed her eyes in the bed and lay perfectly still with her eyes closed, she was still having vertigo. There are two types of vertigo: peripheral, which means it's coming from sort of the ears out, and central, which means it's coming from the brain. This suggested that this was central vertigo. And I got lucky, and we did the right test. And here is a stroke where an embolus has gone up to her brain and infarcted her cerebellum, causing her to be off balance and causing her vertigo as well. I had to break the news to her that this clot came from, the embolus is a blood clot, and it came from somewhere. It could have come from her neck. It could have come from her heart. In the setting of COVID, this was before the COVID era, it could have been due to hypercoagulability. We're seeing many neurological things with COVID. Or this was a patient I had not too long ago who was a young adult with back pain. Very, very nice person with a nice family who had been told recently that this person had developed lymphoma. Lymphoma is lymph gland cancer. And the lymph gland cancer had spread all over this patient's body, including to this vertebra right here. This is cancer lymphoma cancer that is spread to this vertebra, and this vertebra has broken through here and through here, causing bleeding posteriorly. See how big the spinal cord is here? This dark area is pressure on the spinal cord. This person came to the ER because they were hurting horribly. Even though the patient was on morphine at home, it just wasn't enough. And so I brought the patient in, I treated the patient with stronger pain medication and got the patient comfortable. The patient knew, and I knew perfectly well, that the end of the line was probably not too far away for this patient. And I just sat and talked with the patient, and I said to the patient, I'm praying for your healing, that you will get better. And the patient said, thank you so much. I'm praying for the same. And then we just sat there for a minute. Or this guy. So here's a guy who lives out on the street, who comes in because he's itching on his leg. This is his his left calf, I beg your pardon. And what you see here are fairly normal skin up here. This is thickened skin here. This is broken down skin here, partial thickness skin loss. This is all partial thickness skin loss. And these are maggots here that are eating the dead skin. Now, initially, you might be horrified about that, but in fact, maggots eat the dead skin that's there. They eat it away and actually put the skin underneath to be quite clean. Now, clearly, we're going to kill all those maggots when we put this guy in the hospital and arrange for skin grafts for him. But how does one not turn up your nose or almost throw up yourself when you come into a room with a guy with a leg full of maggots? And the answer is that with the passing of time, it gets to the point where not much surprises you anymore. And we took care of this guy, and he came in the hospital, he got skin grafted, and he went back home. And so as we get close to the end here, I want to tell you a story, and it's called The Melting of the Rings. And the story was that me as a doctor in my family. And this is the story of my dad. My dad was a bad dude. This is my dad at the age of, in his early 80s, Alpha was his name, like Alpha, Beta, Gamma, Alpha. And this is him sitting in in front of his airplane, N3483 Yankee, tail driver. He was a hell of a pilot. My dad was a bad dude. My dad in World War II was a squadron commander for a B-17 bomber group. He was based in Pisa, Italy, and he flew bombing raids over Austria. And he flew all the way up until the VE Day, Victory in Europe Day in June of 1945, where my dad was from Douglasville, Georgia, my hometown west of Atlanta, where he heard that there was a young lady down on the Isle of Capri and the Naples, Italy area, who was kind of cute, and he ought to go down and meet her. So he did. The war was now over. The victory was declared. So he went down and met Mary Hodgson, who was to later become his wife. They fell in love. It was a quick falling in love. In the space of a couple of months, they decided to get married. And so in August of 1945, they went to the jeweler there on the island, and they said, "We're going to get married. We want to get some rings, and we want the rings to be gold rings, and we want them to look alike." And so the jeweler says, "Oh, we got no gold. Mussolini, he takes all the gold." With Italian, you have to. Mussolini, he takes all the gold. We got no gold. And my dad says, "Well, we've got to have rings." And the jeweler says, "Well, come back in 2 weeks." So they came back in 2 weeks, and the jeweler had the rings. And my dad says, "Well, I thought you didn't have rings. I thought that there was no gold and that Mussolini took all the gold." And the jeweler says, "Well, I went down to the morgue," which means he pulled the teeth of dead Italians and made rings for my mother and father. That's a true story. On August the 8th of 2003, in Douglasville, Georgia, now retired, he was still worked in the bank some, he was a retired bank president, was with my mom on a Sunday afternoon where he came in right after Sunday dinner. They had taught Sunday school together that day, and he was clutching his chest and said, "Susie, I feel terrible."
And so my mom, knowing her son was this hotshot EMS medical director of the ambulance service, rather than calling 911, promptly piled Dad into the car and drove him to the hospital. Fortunately, it was only a couple of miles down, but he was in shock and he was really sick when he got there. It was determined that Dad had had a massive inferior wall myocardial infarction, that he'd also taken out part of his mitral valve, and that he needed to be operated on. So on day one, we took him over to Piedmont Hospital, where this is Dad getting ready for, he is getting pre-op for surgery, and they went ahead and took him into surgery. And here he is in pre-op day one, having had his chest split open and his mitral valve replaced. And in pre-op day one, he's doing pretty good. His pressure is 137/61. His mean arterial pressure is good. His pulse oximetries look good. He has a nice regular rhythm, and so forth. Here is Uncle Oscar, his younger brother, taking a nap there in the waiting room. Here is my mom witnessing to someone in the waiting room, to a total stranger. Here are the girls, the granddaughters coming in to be with Dad, who is just recovering post-op. Here are the granddaughters talking to the nurse who's taking care of my dad. And here is my dad, post-op day one, doing pretty well. Got a big smile for us. Here's Mom kind of worn out in the waiting room. And Dad says, "Did you bring your checkbook? Pay the man. Let's go home." And this was on August the 9th. And Dad gave us a big smile. On the final day, Dad had, on the second day, Dad had a terrible turn for the worse. He became very short of breath. His lungs filled up with fluid. He went into shock. He is in an irregular rhythm now. His pulse, his oxygen levels are low. His blood pressure is low. And he was looking really bad. And here was Dad there in the bed, just much changed. His level of consciousness has now changed. He's really not responding. Here is his youngest brother, Jimmy. Jimmy is a plastic surgeon in Salt Lake City. There is my mom with my youngest brother with Dad. There are 3 of the 4 boys and Mom with Dad. And there is my mom with what I think was the last picture that was taken of her and Dad when Dad was still alive. And there is Jimmy, his youngest brother, with Dad, holding his hand, knowing the fact he's taken a bad turn for the worse. Dad came to for an instant and said, "Jimmy," and then there was silence. Well, by that time, I'd been practicing medicine about 30 years. I thought I knew a lot, but I knew one thing. I knew that I had to be back in Dallas to work Parkland the next day. And I also knew Dad was either going to get really better or he was going to die. And honestly, I just chose that I did not want to be there at Dad's bedside when he was dying, when they were doing CPR on my father. So I flew back, and I got back to Dallas and went to bed. And the next morning, my brother calls me and says on the morning of day 3 that they had to do CPR on him, and he has gone home. And this was at 11 a.m. on August the 10th of 2003. All by myself in my apartment, no family here, knowing my dad was there. And so I found out what you do when a close family member of yours is dying or has died, is that you go sit by the window and just stare out the window. And I went to work at 3 o'clock, and one of the attendings said, "How's your dad?" I said, "He passed this morning." And he said, "What are you doing here?" And I said, "My dad would have gone to work, and so I'm here." So my father, a soldier, a statesman, a father, and a friend. What followed was interesting. After the funeral and all the grief starts to settle, I was sitting with my mama, and I said, "Mom, now there are 2 rings, and you've got one, and I'm going to take Dad's ring. It's the other, and I don't know. I mean, what should we do with the 2 rings?" And Mom said, "I think you should melt them together and turn them into 1 ring." And I said, "I just don't think that I can do that." So what instead was that I brought Dad's ring home, and this is my father's ring from August, when they got married, August 18th of 1945, and then that he wore for all of those years. So thoughts in closing. I like this one. The 10 things that likable people never, ever do. And this includes doctors, and why you love them for it. They don't blame, they don't control, they don't try to impress, they don't cling, they don't interrupt, they don't whine, they don't criticize, they don't preach, they don't live in the past, and they don't let fear hold them back. So as we think about where our eternity is going to be, whatever your belief structure is, to which it's totally valid for you, as we make those decisions, we must remember that as we approach the field of medicine, that medicine gives us a seat on the highest peaks of human existence. And we have but to open our eyes, and we will see it all. For as we remember from the old Shaker song about plowing the fields, 'tis a gift to be simple, 'tis a gift to be free, 'tis a gift to come down where we ought to be. And when we find ourselves in the place just right, 'twill be in the valley of love and delight. When true simplicity is gained, to bow and to bend, we shan't be ashamed. To turn will be our delight, till by turning, we come round right. Thank you so much. Well, Rachel, take a sip of water here. Oh my goodness. All right. So
Trip down memory lane, huh?
Trip down memory lane.
Thank you so much for sharing your beautiful stories throughout your life and career. We have a lot of questions. First,
make sure Brandon's there somewhere. All right, so let's go.
First, how do you deal with your personal beliefs when treating a felon, a perpetrator, or abuser? And how do you not keep that in mind when you're treating them?
Part of maturity is learning not to put your belief structure onto other people. Medicine is applied science, so I have to do a history and a physical, evaluate, do testing, and then do a diagnosis. So I have to get all that done. Even if the guy is guilty of a tough crime, maybe kill somebody or has done something awful or has done great destruction to his life, what you will find is that if you let emotion or judgment get in your way, it will cause you to limit your differential diagnosis. I'm going to say that again. If you allow emotion or judgment to get in your way, it can limit the ability of you to apply a differential diagnosis. So it comes with maturity. You may already be good at it, but just be certain that with the passing of time, we have to accept that people are where they are and we are where we are. Next question.
So going off of that, in the ER, is there a way to protect victims from their abusers if you have to treat both the felon or the perpetrator or the abuser and the victim?
Absolutely. I love Parkland Hospital for a lot of reasons. It's a huge hospital. It's a county hospital, and we have police in-house in the ER 24/7. We also have a full psychiatry service, psych ER, whom you will hear from in a couple of weeks, 24/7. We also have a violence and injury protection staff that will come down. And so we have sufficient staff to be able to, number one, separate people in case they're still fighting. Number two, surround them with resources, including, let's say, a woman got beat up by a husband. Now she has nowhere to go. She can't go home. She's afraid to go home. That we will arrange for the resources to help her find appropriate place to stay and care and resources until such time. Okay, next question.
Goodness gracious, there are a lot of questions coming in. So how have you dealt with making a mistake or someone dying on your care? And then how do you not let that affect your next patient?
There was a friend of mine that, Brandon, we ought to get Bill Norcross to come talk. He would be such an angel.
Absolutely.
Bill's a little older than me. He's a lovely, lovely man and one of the finest physicians I've ever known. And Bill and I both talked about the ghosts. These are the ghosts of the patients that have come before that didn't do well, and they live back here, and they remind you, you remember me? You remember when you forgot to do this or that, and I got worse? Any doctor that's going to be in medicine long enough is going to have patients who have a bad outcome. The critical thing is to not be too hard on yourself. Now, having said that, I will say that the hardest butt I kick, and I bet Brandon feels the same way, is my own. If I do something that is just not, if I made a clinical error, which I like to think I haven't done in a while, but if I make a clinical error, the hardest butt that I kick, the butt I kick the hardest is my own. And because I make myself learn from that, never make the same mistake twice. Search around the issue for related errors where a similar error might have been made. Brandon, what do you think about that?
Yeah, it's important to remember, we're human. We're going to make mistakes. It is a very challenging position that we're put in as physicians, that society expects us to be 100% accurate all the time, no mistakes, no excuses, on top of our game. And it's a really tough position to be put in. I've certainly made mistakes. Very young into my career, I've already been sued. I may turn that into a talk eventually when I'm ready for it. I think it'd be something good to teach the residents. But it's, we learn from these mistakes. We need to know our limitations, our knowledge deficiencies, and we need to make sure that we're always trying to get better today than we were the day before. And you don't always learn from just textbooks or lectures. If you think about it, every patient is also teaching you something as well. You just have to listen to them.
Rachel?
Has there been an instance where the patient has threatened your safety? How do you deal with those cases?
Well, that hasn't happened since last week. I had a prisoner coming off the bed last week. The only weapon the prisoner had, except for fingernails, was spit, with the risk that I would be spit in the eye with something that the patient might have had. I don't know that the patient had any infectious diseases, but that was a risk. But this is where you have to be very careful. The first decision you make as you approach the patient is, can you be there? This applies to if you get involved with triage decisions. For example, if a bomb goes off somewhere, or a house catches fire, or you do a ride out with EMS to see how things are in the field. The first question is, can I be in here? And if you cannot, don't go in there. It is not your job to die. The second corollary to that is, never let a patient really get between you and the door, especially a psychiatric patient or a patient that may become violent. And if there's any question about the patient's propensity for violence, don't let them get in between you and the door, because they can block your exit. So you have to be really careful and use good sense. And remember that you protect yourself first, your staff around you, so that you can take care of the patient.
All right. Next question. I guess it's also open to Dr. Marchetti and Dr. Salazar. How do you guys handle being sued, or have you guys been sued in your practice?
Brandon, you want to take it?
Yeah, I had a case as a resident moonlighting that didn't go well, and got sued from it. It makes you question your career choices, makes you question medical decision making. It changes the way you practice and the way you approach patients. I don't know if handling it is the right word. It handles you. You have mentors, like Dr. Fowler says, and you learn from it. You know what you did wrong. Sometimes you're under scrutiny that's not really accurate, but you can't really defend it that well. So in the end, it's having people to kind of walk you through it who have been there before. Again, maybe one day I'll actually put that to a talk and give it to you guys.
Gil, if you're still there, speak up.
Yeah, and it's not just lawsuits. Occasionally, the care you provide to a patient is brought under question because of a untoward outcome. And when you find out that somebody's looking at your case and investigating it, it never feels good. You don't sleep very well for that night, and you question why you do what you do sometimes. And so I'll give you this piece of advice is eventually you realize that it's not personal. It's not you. It's you are trying to become better, and folks are trying to make patient care better, and you eventually don't you stop taking it personally. But it never feels good, no matter who you are. But I do have to echo Brandon's comment that at the end of the day, we're there for each other, and that's what matters most. Somebody to hold your hand through it has been the most valuable thing for me.
I ran a company for 20 years back in Georgia, which was an emergency medicine company. And the company would get sued about once every 2 years. It quickly lost its enamor for me. We were sued for $6 million one time. We were found not liable, but we had to try it. We had to go all the way to jury because we didn't cause a problem, but we were sued anyway. The things that you learn from that is that you're in medicine for a reason. And that reason is to take care of people, to work in an applied science, to be around the wonderful fellow caregivers. And it's more like when, not if, that you get called into a case at some point in your career that you do what Gil said, is that you handle it with the proper mental tone. Don't question yourself, and just know that you tried to do the best that you could do. Rachel?
So some of our students have asked, how do you go about seeing, addiction and abuse? Do you report it to authorities? How does that process kind of work?
Well, someone who is addicted to heroin that comes to see me, even though heroin is an illegal drug, excuse me, I'm not going to report him to the police, even though what he is doing is illegal. What I'm going to do is take care of the physical needs and also attempt to take care of the psychiatric needs so that we can hopefully get him into a program so he'll go into remission and no longer use the heroin. We know that a heroin person that is overdosed, that we give Narcan to and wake them up, has at least 5% chance of dying in the next year. And so my principal concern is life, and to try to help this person preserve their life. Now, there are things that you do have to report. For example, if a woman comes in and says that she was beaten by her husband, we will give her the opportunity to speak to the police so that she can press charges. At the same time, we will get the violence and injury protection people to work with her so that we can try to make sure that she has a secure place to go. I think that answers that.
Yeah. Next question is, has politics of a hospital ever gotten in the way of a patient's treatment?
Well, the politics of the hospital. The hospital has two main parts, the administrative staff and the medical staff. The medical staff is generally far larger than the administrative staff, though some hospitals have very large administrative staffs. I did find, when I was younger, that the smaller the hospital, the greater the politics amongst the physicians within what's called the medical staff group at medical staff meetings. And so, yes, there could be folks who were friends of each other who might indeed be allied. The way that I addressed that for years, in the first 20 years there and the second 20 years here, is to just attempt to do a good job, and gradually, with the passing of time, to try to make friends with the consultants that I call so that they know who I am and the fact that hopefully I'm thinking reasonably about patient care. It's also important, I think, to stay out of hospital politics by and large, because you can get yourself on the wrong end of, say, a referral situation. That is just pointless to do that. So the important point is to do the best you can, do a good job, make good friends with your consultants, with the hope that what will come from that is good relationships with all the medical staff and the administrators of the hospital. Okay, Rachel.
What are your thoughts on mental health awareness in the medical field? What help and advisory are for physicians, nurses, physician assistants, and other medical staff when dealing with mental health crisis?
Well, there's several things in that question there. The first part I was hearing was about mental health among physicians and medical people. I believe that's correct. There's no question that physicians, nurses, techs, medics, and so forth are normal people. You might consider them a little weird. Sometimes they deal with the sick and dying, but they're also human. There has been an enormous epidemic of fatigue and depression amongst medical providers during the COVID epidemic. Enormous. There have been people quitting. There have been physicians and nurses quitting, saying, I'm just not going to do this anymore. And Gil Salazar put it really well. Gil talked about the three key issues of what he does to help maintain his mental health. And when Dr. Luna, I'm sorry, I'm hesitating. When Dr. Luna spoke a few weeks ago, he's on the medical board for the state of Texas. And I just read the medical board's bulletin. It comes out once a month, and it came in the mail today, and I read it. And it talks about just how many ways of mental health that physicians get in trouble. It's depression, it's alcohol, it's writing prescriptions and taking them themselves and so forth. And it is so important that you follow the basic guidelines of seeking after mental health, because if you can't take care of yourself, then you can't take care of anybody else.
If I may, I know we're getting short on time here, just something I want to add that may affect you guys by the time you're ready to start applying for a medical license near the end of your training. But whenever you apply for a license on your application, it asks you questions about, are you able to perform this job? Do you have anything that would stop you? Do you take any medications? Have you ever been under the treatment of a physician for mental health issues? And really what that's doing is setting you up to either recognize seeking treatment as a stigma or something that's almost unheard of in medicine, or setting you up to lie on an application, which we don't encourage you to do. So there's been a lot of push over the last few months to take this question out of medical licensing applications, because there's a lot of physicians that need help. If we are not in a good place, we cannot help our patients. And so these licensing boards are really feeling the push right now by a lot of professional organizations to remove questions like this. So by the time you guys are ready to apply for a license, it may be an unheard of thing to ask such a ridiculous question.
That's great. Rachel, let's take one more, then we'll be right at 9 o'clock.
Goodness. Oh, what is that? Have you ever dealt with doubt in your diagnosis as an ER doctor? And how, I guess another question off of that is, do you get to see your patients in the long run after they see you in the ER? Like, do you get to check up on them?
Well, there are two questions there. One about how do you deal with doubt, and then the other is the long-term follow-up or some kind of follow-up on patients. I find doubt very healthy. I question my diagnosis all the time. I mean, some things are straightforward. Cut finger, okay, fine, that's easy. But an odd abdominal pain, an odd chest pain, an odd presenting group of neurologic symptoms that really needs to have a diagnosis made, I really work hard to get the diagnosis, and I keep chiseling away at a diagnosis that I come to, saying, well, what if it isn't this? Okay, well, let's back off a little. Let's approach it again. The difference between a generalist, which is an average physician, and a specialist is in the rigor of the application of a differential diagnosis. And so what will make you, all of you still listening to this, a great doc or nurse or PA one day is rigor in the application of a differential diagnosis. Then as far as seeing people long-term, again, I'm at an urban center here. The people I actually see long-term, and this will make Brandon and Gil smile because they'll agree with it, is the alcoholics and druggies that keep coming back time and time and time and time again. We had one alcoholic that died not too long ago, who would come every single day, often twice a day, occasionally 3 times a day, and once in a while 4 times a day to the ER. Nowhere else to go. We slept on the street. You know, I understand that, but in the meantime, this person was drinking himself to death, and ultimately died of alcoholism. I mean, the alcohol killed him. So, you know, we hope to try to be able to make a difference in people's lives, and when we see folks back with alcohol and drug abuse, then we just know that the system is imperfect and we must continue to search for solutions to help people help themselves. Rachel, thank you for all the questions. Gil and Brandon, thank you so much. And Rachel, you want to wrap it up and we'll do the last slide?
Yes. Can you go to the next slide, please? All right, so this is the information for assessment number 19. Again, you do not need a QuestBase account to access the assessment. Just go to questbase.com, go to find assessment and enter in the PIN with the dashes and enter in the password. It has no caps, it has no spaces. You have until next Tuesday at 6:59 p.m. Central Standard Time to complete the assessment. If you have any issues with the assessment, please let us know as soon as possible. Email us at virtualshadowing@gmail.com. We will also send out this information in our weekly email, so stay tuned for that tomorrow. We'll have the reading assessment or assignment that Dr. Fowler mentioned earlier, and also information about Dr. Salazar's virtual observation program.
Okay. Well, everybody, we want to thank you for the over 600 of y'all still staying online here. We're going to keep coming back if you keep coming. Like I said, we hit 25,000 original signees on the website today. So it indicates to me that a lot of folks still have a lot of interest. So we want to thank you all for coming. We wish you a great evening and we'll see you all next week. Thank you for